TopMedTalk.
Hello, I'm Desiree Chappell, and this is TopMedTalk. We are live from the European Anesthesiology Congress, EUROANESthesia 2019 in Vienna. I'm here with Editor-in-Chief of TopMedTalk, Monty Mythen.
Good to be here, Desiree.
Hi, Monty. I'm so glad that you're here.
Thank you.
So this weekend, we're going to be sitting down with presenters, key opinion leaders, and delegates to really give you a first-hand look into the Congress. And today, we have the opportunity to catch up with an old friend from EdPom. Hi, John.
Hello, Desiree. How are you this morning?
Good. We have John Koncelik from the Florida Gulf to Bay Anesthesia for TeamHealth, right?
That's correct.
All right.
Yes.
Great. Well, John, thanks for sitting down with us.
It's a pleasure. Absolute pleasure.
Yeah. So it was so nice to see your smiling face come by the booth here.
It was nice to see friends as well walking through the convention center here in Austria. Yes.
Yeah. Who knew? We just wanted to catch up with you because we hadn't talked to you for a while and see what was going on. I know that you're doing a ton of ERAS stuff. And just wanted to kind of get a feel for what's going on there down in Florida at your facility. So just tell us a little bit about what your role is there, what you're doing.
All right.
Give us a little bit about yourself.
Nothing. I'm the facility medical director down at a number of HCA hospitals down in the western coast of Florida. I'm the chief of anesthesiology at 2 facilities as well, too. And we were presented by HCA about 3 years ago to begin looking at ERAS programs to enhance the safety and quality of our patients. Luckily, through going to a number of meetings in the future to that, and ERAS and both the EPOM, I've been able to have the chance to meet both yourself and Monty Mythen and really learn some of the strategies of developing protocols. We were tasked with doing a pilot study in hemicolectomies. We actually found that we reduced our length of stay from 8 to 5 days. We decreased our 30-day readmission rate. We actually created an opioid-free environment for our patients. And we created 200 bed days, which in this certain times of year down in Florida, when we have our guests from the north, the snowbirds arrive by migration, we actually need every bed that we can get. And creating beds has lessened the ER hold and wait time for many of our patients. So that has become a real benefit, not only in safety and quality, but also in the economics of the hospital.
Oh, it's huge.
Can I back you up just a moment there, John? Because for many of our listeners, they won't necessarily know what HCA is. Okay. And it's a big, impressive organisation, but I think it's worth sharing a little bit of that. Right. I'll then move on from that to talk about how they operate.
All right. Hospital Corporation of America is currently a 169 hospital organization in the United States. It is for profit, so there is certain tasks that we have to do to help mobilize patients out. I've actually been a consultant for them for the last 10 years, going to different hospitals within the system and helping address certain situations and problems. This particular hospital I was asked to come to about 3 years ago. There was some cultural and non-financially and time inefficient processes going on, and we have corrected that in the last 3 years.
So, full disclosure, because I work with an HCA organisation in the United Kingdom. Mm-hmm. My NHS hospital is a strategic partner with HCA International. Mm-hmm. And I also work in one of their, very occasionally, my colleagues listening would say, when did you do that last? in one of the private intensive care units. Now, what I understand about HCA in the USA is when you look at the tables of healthcare providing organisations, it is often on the top of the table in terms of numbers.
Yes.
So you said 169?
169 hospitals, and they are now re-engaging in the purchase of ambulatory care centers around the United States. I believe, and this is only estimations at the last meeting, but I think they're going to grow. They're projected to grow by the end of 2019 to a total of 180 hospitals, and I think between 75 and 100 ambulatory care centers.
And it's the number of providers, I think, is where they're often high on.
Yes.
In other words, you've got a lot of cats to herd.
That is correct. That is, and a lot of cultural cats to herd, which also makes it very interesting.
But the other thing I've got the impression with my time spent working with HCA, access to the C-suite, etc., is they get stuff done.
They do.
They make a decision, and I don't know if they encourage people or they crack whips or they just have a cultural expectation, but they seem to get stuff done.
They do. With any large organization, Monty, the inertia is sometimes very slow, because to try and gather that one particular protocol amongst a number of facilities becomes a monumental task. Initially, 3 years ago, there was 5 hospitals in the United States that did the enhanced recovery after surgery. A few did orthopedics, total knees, and there's 3 of us that did the hemicolectomy study. Again, we found it to be exceedingly beneficial. We were at the top of, I think, the 5 hospitals in terms of our general surgery protocols, and currently we are expanding that to include general surgery, hemicolectomies, oncologic surgery. We have recently become a bariatric center of excellence, and partly because of you, to be perfectly honest. When I wrote the protocol for bariatrics, when we came... Yes, you can pat yourself.
No offense, Monty.
For those of you watching on YouTube, I am sucking this in now.
When we visited for our accreditation, the professor from the other facility said that's one of the best bariatric protocols he had ever seen. Wow. So we really extended it greatly. We are now looking at doing hip and knee revisions because of the higher incidence, particularly in our elderly populations of acute renal injury after the procedures, and we are now looking at multi-level back surgery.
And I think that's a point that's often missed. Revision joints, that's high-risk surgery.
Yeah, Correct,
totally.
Yes.
People just think, I had a joint the last time, not a problem. Revision joints is serious stuff.
That is correct. Yeah. Well, you illustrate a point. In the elderly population down in Southwest Florida and probably all over the United States, not only do they come in probably ill-prepared medically, they are anemic, they are malnutrition, they are dehydrated. So the additional risk factors in meeting this patient population is accentuated by the anesthesia, and also, and I'm sure with your experiences, there's more blood loss, there's certainly a bigger change in fluid balance in these particular patient populations as opposed to the routine elective knee and hip surgery.
Yeah, Absolutely. It's definitely underappreciated for sure. So you said you are expanding into some other...
That's correct.
Yeah, so do you think you're ever going to get to ERAS for all, John?
You know what I'm trying to do? I will tell you that I have just been nominated to a committee by HCA. They are developing a new quality and safety dashboard for anesthesia. And one of the 3 platforms they are engaged in is in encouraging and developing ERAS protocols entire all of HCA. So I think one of the reasons that I actually got nominated to this committee was the involvement in ERAS that I've been in already. Yeah. So if you look at it in the United States, currently in 2020, they're going to be looking at around 48 million plus Medicare patients. In 2030, we're looking going up to between 65 and 80 million patients. So the care of these individuals who want to stay active, to want to maintain a lifestyle in their retirement, we are going to have to do better to get them out of the hospital safer and with more quality and less adverse side effects. So from an anesthesia point of view, what we're driving, and I only ask 3 things, trying to make this minimalistic so it's simple, is to reduce the opioid burden as much as we can to 0 if we can. Number 2, very acute observation and control of postoperative nausea and vomiting. As you're both aware, that can certainly increase the cost and length of stay. And number 3 is goal-directed fluid therapy to make sure they are as euvolemic as we possibly can so we control all end organ issues that can occur.
John, do you get most of your patients back home, i.e. the home they came from, or is there a high use of intermediate care facilities?
It all depends on the preoperative morbidity and mortality. Okay. We do send some to skilled nursing facilities. The majority, if we do a good job in controlling those 3 parameters and can keep them off of opioids, and they have good social support at home, then we try to get them home. Unfortunately, we do have a number of seniors who are living by themselves and are probably not the best candidates for going home by themselves.
And how's your outreach? Because I think everyone notices elderly patients, most of them like to get home.
Yes.
They like the familiar environment, whatever it's the pets, they know where stuff is. But they sometimes need support for a number of days. Are there outreach support systems you can call upon?
There are. There is home health nursing that can be directed. And I believe our case managers do a very good job at the hospital in getting them the support that they actually need to do that.
Yeah, case managers and discharge planners are really, really They're so good at that.
Well, do you want to explain that a little bit more for the patients or for the population listening to this that don't understand what that is? Because I don't know if that is a phenomenon in other countries.
Yeah, I don't know.
It is. It comes in numerous different guises. So in some parts of Europe, the district nurse.
That's what I was just going to say.
Is still, which my mother was a district nurse for. I hope you're listening, Mum. They would. In different guises, they would provide all of those services.
Yeah.
Now, it just comes in different ways in different places.
Packaged
but
up.
Many more skilled nursing facilities also now, if you're paying directly, whether it's cash or via insurance, now have extended to become outreach services as well, because they do the same job, as they just do it in your room, not their room. And I think that's good progress.
I was reading through some nursing materials, some journals and some things, and the wave of community health that they're really pushing within the nursing community now. I mean, it's always been around, but now I think there's really a huge opportunity for nurses to go back into the community and do sort of some of these things.
Sometimes in the US, as there is in remote parts of the UK, it's geography eventually becomes one of the barriers.
That's true.
Yeah.
That's true. Well, that's particularly in some of our underserved and rural areas, which we do have in Florida, in the central part of the state, where there aren't the facilities to do that. So to maximize the patient's recovery and getting them home in the least post-operative need they have is very, very beneficial. If you expect some of those resources to be available to our seniors that are in underserved or rural areas, they just because of economy probably won't happen.
Yeah. John, I have one more question before we wrap up here. A lot of our listeners are always asking, how do we herd the cats? How do we get these people to do what they need to do? And, I think our discussion about, discharge planners, care managers, nurses out in the community from, and then extend that beyond the continuum of care, for these patients. And we have so many providers touching these patients in these enhanced recovery pathways. How do you herd the cats? Like, how do you get this whole team together to make something like this work?
Okay, well, that's a really good question, Desiree. The protocols themselves are excellent, getting people to buy into them once they've been exposed to them. But one of the things that originally happened was surgeons and chief medical officers were tasked with driving this. And the orthopedic surgeon is not going to have the same influence on a gastro or general surgeon doing some type of intra-abdominal procedure. So that's where I think the role of anesthesia and anesthesia personnel and anesthesiologists come in. If there is a certain specialty to be, I think we should be the goal-directed champions of this particular specialty. And with anesthesiologists and nurse anesthetists' influence within the hospital, being able to touch all the different surgical specialties and the hospital administration. I have found that when I have reluctant surgeons, the CEO and the chief financial officer are my best advocates in driving these protocols. So there's a different paradigm in how we do this. And one of the other difficulties in the United States, Monty, that you've touched on already, is there's cultural differences in every hospital. So learning the cultural differences and then identifying your champions are key for driving ERAS in American hospitals.
Yeah.
As an organization, I mean, every organization will claim that it's data-driven or data-driven. But I got the impression that HCA, it's very, very much data-driven.
It's
not exactly. It's not the patient comes first. That's what it's all about. But I got the impression that quality is recognized as delivering value, and value is good business.
That is correct.
Yeah.
Well, value is good business not only from the outcome of reduced admissions, decreased opioid, but as I mentioned, we created 200 bed days.
Yeah.
And to have available slots for patients that need care. Is there any number that you can put a financial number on it?
You've got that data at your fingertips.
Yes, I do.
For all the facilities that you're looking after.
Well, not for all, for mine, but I am hoping now that I have been invited to this new quality and safety committee advisory board that I will have more of that information in the upcoming months.
Yeah, and creating those dashboards for everybody.
Correct.
Yeah.
Exactly.
Very cool.
Exactly.
Very cool. Well, John, such a pleasure to see you.
Thanks so much.
Thank you so much for sitting down with us and getting it.
And don't forget to come back to Dingle.
I won't. I will. For those of you who don't know, Monty has a course in Dingle, and I was there 2 years ago, one of the most unbelievable presentations and facilities and presentations, yet the town is absolutely enduring and gorgeous, and I would actually go back there to live there for 6 months. It is that nice.
Every single person that talks about Dingle says the same thing.
Of course, half of Monty's family is in Dingle and owns the bars as well, too.
Well, on that note, John, again, thanks so much. We look forward to seeing you at future EdPom meetings and seeing your progress and what you're doing at HCA.
Thank you very much.
Yeah, thanks.
I'm glad that you had me. Thank you.
Yeah,
Thanks, John.
yeah. So, again, be sure to follow us on your favorite social media platform, Twitter, LinkedIn, Facebook, Instagram. We're all over that. We're going to be coming to you live all weekend at Euroanaesthesia 2019. Thanks for listening. Cheers.
TopMedTalk.
Nick Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.